Yeah, very good evening, dear my professional colleagues. I welcome all you to this the webinar on insulins, and thanks to Mr. Hamid for his kind introduction. And I'm thankful to Novanadis for giving me this opportunity to be the first speaker of this session, and followed by the second speaker, Dr. Sepuri Devi ma'am. And I am Dr. Sepuri Krishna Mohan. I am an endocrinologist at my own center, Sepuri Diabetes and Endocrine Center, Kurnool. So today we are going to talk about the unique formulation, that is the only one and only co-formulation available on the earth. That is the insulin, the aspart and the insulin declodec. It's a combination of the insulin aspart and the declodec. So now people have given a brief introduction about the centenary celebrations which were over in 2022 actually, the 100 years of the insulin actually. So crores and crores of people are living with the discovery of insulin by Dr. Grant Frederick Banting, and that was done at the University of Toronto. Basically, he was an orthopedic surgeon, but at a very young age, he determined himself to discover this particular insulin. For that, he bothered the professor of physiology at that time, the head of the department of physiology, Mr. J.J.R. MacLeod. So after some time, he was not convinced actually why this young man who is an orthopedic surgeon, he says he wanted to discover insulin and all, but finally Banting succeeded in making MacLeod give him a lab and 10 dogs, an unused, dirty, small room with 10 dogs. So he started this with Charles H. Best, so who was the assistant for this particular gentleman who discovered the insulin, Grant Frederick Banting. And after he started his this thing, the research work, and prior to that, Von Mering was the scientist who has proven that the pancreatectomized dog developed diabetes. So he started doing the same procedure and he induced diabetes, and then he started extracting the insulin from the beta cells of the dog. So initially he prepared a crude insulin which was not purified, and the Guinness Book of Records, it is given that Leonard Thompson, a boy aged around 14 years, was suffering from type 1 diabetes, and he was about to die in the Royal General Hospital, Toronto. So the ethics committee in 21 actually, so gave permission for this Dr. James Grant Frederick to give this injection to that dying boy. So the blood sugar was somewhere around 400 to 450, and he gave the insulin, but it did not show a drastic relief at all. So the blood sugar was reduced to tune of only 30 to 50 points. So then they made out that so this is not a product. So then the young chemist James Colip has come into play, and he started doing this the work of purification of the crude insulin. Then again, the insulin was purified, and then the same boy was given this particular insulin, and it started showing the dramatic this thing. The ketones disappeared. He was in DKA actually, the type 1 boy, the Leonard Thompson, and then later on he improved, and he survived until 28 years, like another 14 years of grace period with this basic insulin. And very unfortunately, he died of pneumonia. So there was no antibiotics at that time. And again, the Nobel Committee in 2023 decided to give Nobel Prize to James Frederick Banting, and to the professor J.J.R. MacLeod, professor of physiology, who has done nothing but for giving the dirty room and the dogs. But this grant, Frederick Banting refused that Nobel Prize, and he asked the committee of the Nobel Prize that the prize should be shared among the four equally. That is, with the Charles H. Best and James Colip. Uh, then Nobel Committee again reconsidered and said, okay, permitting Grant Fredering to share his Nobel Prize with Charles H. Best. And though it was not liked by the Professor J.J.R. MacLeod, who was little bit selfish, he was not like Grant Frederick Banting actually. So he shared his Nobel Prize with James Colip. So on record, it is for MacLeod and the main discoverer, the Grant Frederick Banting. So later on, the greatest help the Banting did to the humankind is, he said there is no patency, no royalty for insulin. That was the greatest thing. Otherwise, you would have been at least 100 times more wealthier person than the Bill Gates or uh, the other the richest people on the earth. So he revised his will again, and he said, it doesn't belong to me, and it doesn't belong to my successors or my legal heirs also. It belongs only to the patients, that's all. So then Novo Nordisk came into scene, and okay, they started producing the insulin in bulk, and Eli Lilly also joined hands, and these are the two companies which produce the commercial insulin actually. So then you know the scenario. And prior to 1922, no type 1 boy survived for more than 3 to 6 months in the entire history. So the treatment was only like starvation, starvation, starvation. And they used to die of the diabetic ketoacidosis, and no mother on the earth suffering from the gestational diabetes mellitus gave birth to a live child actually. So that is the greatest aspect of insulin. So with this brief introduction, I think we'll get into the sessions. Yeah. Today we are going to talk about this particular topic, a clinical perspective on the complexities and the challenges of diabetes management in India. And this is my financial disclosure. And today's agenda is divided into four parts actually: the state of nation, and the need of insulin therapy, how to initiate insulin, and the last one is the choice of insulin at initiation. And coming to the first part, you know that the development of type 2 diabetes is progressive. It's a relentless process. Once you get diabetes, it doesn't stop, right? It progresses. And every time I tell you the natural course of the type 2 diabetes, that is the pathophysiological scenario behind the type 2 diabetes is, on the one hand, it is a normoglycemia. Slowly, the patient gets into this particular state of impaired fasting glucose, followed by the impaired glucose tolerance, and then on to over diabetes. This is the natural history, and we always should remember my mentor, the Rolf Anthony Di Franjo, who said, from the theory of the triumvirate, he postulated the theory of the ominous octet. Actually, the basic eight culprits which are involved in the pathophysiology of development of type 2 diabetes. This was done in the ADA scientific sessions at New Orleans in 2019. In that was he was the speaker for this the Banting's lecture. So I was we both were physically present to listen to Dr. Ralph Anthony Di Franjo. The normal regulation of glucose metabolism is determined by a feedback loop involving the islet beta cell and insulin sensitive tissues. And on the left hand side, you can see it starts with the insulin resistance. The pathology is simple. One is insulin resistance, and the second is insulinopenia. And we, as Asians, especially the Southeast Asian, that is the Indian subcontinent, we have got more of insulin resistance than insulinopenia. When compared to the Caucasians, the whites, they have more of insulinopenia rather than the insulin resistance. So the insulin resistance predominates in Indian scenario. So these are the realities of the pathophysiology, and the socio-economic and the cultural variations. What we have when compared to the Caucasians. So that's the reason the treatment has become so complex as far as our Indian type 2 diabetes patients are concerned, actually. So, and the beta cells increase insulin output to maintain the normal glucose tolerance, and so the insulin resistance leads to progressive beta cell failure on the one hand, and this is a vicious cycle. So it is vice versa. So again, the progressive beta cell failure leads to more of insulin resistance, and put together that leads to postprandial plasma glucose levels, and they begin to rise, leading to fasting plasma glucose levels start rising. That is what we call the impaired fasting glucose, and then the impaired glucose tolerance. That is all the time the diagnosis of in impaired glucose tolerance is done by 75 grams of the glucose, and you need to test the 2 hour post glucose 75 grams. So then if it is in between 140 to 199, it is the IGT, and if the blood sugars are in between 100 to 125, it is impaired fasting glucose, and the normal is fasting is less than 100 is considered normal, that the patient doesn't have anything, and the post lunch or the 2 hour this thing is post glucose less than 140, means that the patient is not suffering from diabetes. And the intermediary phase we have, that is cat on the wall, that is called the pre-diabetes, and next they move on to over diabetes. And this progressive beta cell failure determines the rate of the disease progression on the other hand, and that leads to decline in the insulin secretion, and further the prolonged chronic stimulation with the glucose and non-glucose secretagogues lead to the beta cell exhaustion. So that is what we call the pancreatic bankruptcy. Always remember, whenever the functioning pancreatic beta cell reserve goes below 75%, that is the existing functioning beta cells are around 25% or less than that. So nothing is going to be fruitful other than insulin. No OAD would act. And this particular scenario, what I said, that is called almost a pancreatic bankruptcy. So 100% beta cells will die in case of type 1 diabetes, and type 2 diabetes you have some amount of insulin, but that is not sufficient to cope with the food intake the one takes. So it is not able to maintain the carbohydrate metabolism, and the equilibrium homeostasis is not maintained. And the diabetic burden in India lies like on the left hand side, you can see the ICMR 2021, and on the right hand side, you can see the World Health Organization. What it says is the prevalence of diabetes in India stands at 11.4%, and 15.3% of the people have prediabetes. And in 2021, the number of diabetes is around 101 million, and it is the latest data. Earlier, we used to say 77 million, which is wrong as per the International the Diabetes Federation ninth atlas, but 10th atlas they have revised actually, and now the current one running is the 10th atlas of International Diabetes Federation, Brussels, Belgium, and the number of prediabetes is 136 million. And according to WHO, more than 50% of the people are unaware of their diabetic status, which leads to the health complications if not detected and treated early. This holds good as far as the diabetes is concerned, as well as the hypertension is concerned. Hypertension is still worse than this. So even 60% and more than that who are suffering from hypertension in India, they don't know that they have hypertension. And this is not totally different from the so-called the world's number one big boss, the most developed country, the United States of America. Also, the scenario is same. Only 50% of the people know that they have hypertension. The remaining 50% of the patients who have hypertension in the United States of America, they don't know that they have hypertension. This is the scenario in the developed countries or the developing countries. So, and underdeveloped countries, it is still worse. Yeah, the burden of diabetes in India. So, 101 million people with diabetes, and the 2% higher average A1C. The ADA recommendation of the target A1C to the goal is around or less than 7%. And in our scenario, it is the 2% is more than the 7. That means most of the people they are maintaining around 9 or more percent of the HbA1c, and only 16% of the population who are taking the treatment are controlled on therapy. So all this and the population that has relatively earlier, the why Indians are the very peculiar is that the diabetes occurs at least 10 years prior to that of when compared to Caucasians, and we have higher insulin resistance when compared to Caucasians, and greater insulin secretory defect compared to their Western counterparts. So, coming to the Asian Indian phenotype, the four classes were the thin fat Indians, the higher insulin resistance, early decline in the beta cell mass, higher risk for diabetes complications. In a subject who eats three times a day, 50% of the day is spent in the postprandial state. So Indian scenario is worse owing to high carbohydrate diet. So you take the all parts like south to north, east to west, and the central part of India. All the five parts of India, on an average, they take around 60 to 70% of carbohydrate in their daily total meal, which is relatively very high. On an average, it is around some 60 to 65%, not less than that. So on the right hand side, you can see the bar diagram showing the first one, the postprandial state, and the post-absorptive stage is light blue, and then dark blue is postprandial state, and the green is the fasting state. You can still see the breakfast. You find more of this particular the postprandial state and the post absorptive state than the fasting state. And even after the lunch, the scenario is same, and the dinner is same. And prior to breakfast only, we find the patient in fasting state. So most of the time, the patient is in the postprandial phase, which is very important with regards to the development of cardiovascular disease, and the mortality goes up and the morbidity goes up if the patient maintains a normal fasting glucose and an abnormal postprandial excursions. So several studies have proven that the major studies, 7 major studies, out of which the largest being the Honolulu study. Honolulu is the 50th state of the United States of America, which is very far away from this United States of America. That is the Hawaii, the capital city of Hawaii is called Honolulu. So it is somewhere midway in between the this Las Vegas, Los Angeles, and San Diego on one side, and the Japan on the other side. It's midway in the sea. So treatment strategies should address both the meal-related and fasting hyperglycemia for optimum HbA1c control, because you want to maintain the HbA1c. All are important. So the fasting plasma glucose must be controlled, as well as the postprandial plasma glucose is controlled. Then only you get the reasonable HbA1c levels. And high carbohydrate diet is a common Indian reality. We know that, okay, so the northern part, you find 63%, and again the 61% on the eastern side, and these the 66 and the 65 on the eastern part, and the western part 61, the central part being 67%, and the southern part is 61. On an average, the HbA1c is around 8.56 plus or minus 1.8 milligram per deciliter, and the fasting glucose is 172 milligram per deciliter plus or minus like 61.9 milligram per deciliter, and the postprandial glucose, which is terribly high, 253.6, that is plus or minus 92.1. So for an for an identical carbohydrate load, this is the CISA mechanism when compared to the Caucasians and the South Asians. The postprandial glucose peaks 2 to 3 times larger in the South Asians, that is the Indian population, when compared to the Caucasians. So this leads to, in the long term, leads to the increased incidence of the macrovascular complications as well as the microvascular complications, and need for different insulin requirements, especially higher mealtime insulin doses. And the glycemic response to carbohydrates is different in all ethnic groups. You can clearly see the different glycemic responses to the same carbohydrate containing food or glucose load have been reported across the populations. The Asians on the left hand side, you can see Asians present higher glycemic responses than the Caucasians following a common breakfast cereal, that is 60% higher, 63% higher, and a beverage containing 50 grams of glucose, that is 29% higher than that of the Caucasians. And for an identical carbohydrate load, South Asians exhibit postprandial glucose peaks that are 2 to 3 times larger than the Caucasians. So that is that is what it says is the need for a different insulin in our Indian scenario, and the requirements especially are higher, the mealtime insulin dose. So patients do not have good glycemic control despite being on multiple OADs. You can clearly see that they are starting with one OAD, add on to two OADs and three OADs and four OADs, and then we tend to start insulin. So this is not the way we are supposed to. And see, the number of OADs increase, still the A1C goes down. Actually, this is because of the beta cell failure. Actually, so after adding insulin, the situation improves, and this is the inference of this bar diagram on the left hand side. Addition of subsequent OAD doesn't offer benefit. This is the take home message. And on the right hand side, you can see use of multiple OADs driven by convenience, acceptance by the patients, and limited consultation time. And successive OADs that provide a lessening effect, and the substantial benefit from the initiating insulin. So the adherence to lifestyle modification measures is poor. Actually, you can see this particular the bar diagram on the left hand side, which shows the lack of exercise, age, smoking, hypertension, the other comorbidities, and obesity, the dyslipidemia, and the positive family history. And you can clearly see that DAP Care India 2011, which was studied in 6,000 odd type 2 diabetes patients, and only 54.6 patients are complained to the dietary advice. Only 37.2 follow the advice as far as the exercise is concerned. Good dietary and the exercise practices would help to tackle hyperglycemia. Practically, few patients only can significantly change the dietary habits and adopt exercise. See, this is the Indian reality actually. So, coming to the second part, the need of insulin therapy and early intensive therapy for reduction of the risk of complications. You can see every 1% reduction of A1C, that leads to 14% reductions in the heart attacks and 12% reductions in the strokes and 37% reductions in the microvascular disease. That is the reason why we always say that the microvascular complications are more the glycemic dependent, whereas the macrovascular complications are not purely glycemic dependent, because you take the coronary artery disease or the atherosclerotic cardiovascular disease, which includes this particular the coronary artery disease and the strokes. They are multifactorial in origin. The etiology is so wide that only diabetes alone is not responsible for this macrovascular complications. As far as micro is concerned, so it is basically dependent on this particular the blood sugar control. So the lower limb amputation or the fatal peripheral vascular disease is reduced. Both are same. The peripheral vascular disease (PVD) or the peripheral arterial disease (PAD) is reduced by 43%, and deaths related to diabetes, it's reduced by 21%. The United Kingdom prospective diabetes study, the prospective observational study in 23 hospital-based clinics in England, Scotland, and Northern Ireland, that is the landmark trial so far in the history of the diabetes. And the number of patients were around 4,500 and change, and 3,642 included in the analysis of the relative risk. Wikipedia started in 1977, and it was reviewed after 10 years, 87 and 97, 20 years are over, and again 2007 it was reviewed, and 2017 now it is called UKPDS ongoing study. So, still going on. So benefits of insulin therapy, because insulin is a pleiotropic drug actually. So see, apart from reducing the blood sugars, it exerts so many other beneficial effects, and then we call it a pleiotropic drug. So the few pleiotropic drugs we have is, the first one is insulin, and the second is the statin, and third is metformin, and fourth is the SGLT2 inhibitors. So this insulin exerts the cardioprotective and neuroprotective and anti-apoptotic effects, and it lowers the blood sugar, and vasodilation and platelet inhibition, and beta cell rest and improvement in the function, and the anti-thrombotic effect and the antioxidant effect, and it has got the anti-inflammatory effect also. So having all these properties, the way we call insulin a pleiotropic drug actually. So these are the recommendations of RSSDI. This is the clinical practice recommendations 2022 for the usage of insulin. Avoid using insulin as a threat. Alleviate the patient's anxiety about the insulins actually. That is the clinician's part. Don't threaten the patient that unless you take insulin you are going to die. This type of conversation should not be in between the clinician and the patient. You should counsel with patients, and counsel very honestly, counsel so that the patient doesn't feel that the doctor is so rude actually. So the insulin therapy should be considered in all patients failing to achieve glycemic targets on three oral agents, or the A1C is around or more than 9%. Insulin is mandatory as per the American Diabetes Association, and the American College of Endocrinology, and the American Association for the AA's, that is American Association for the Clinical Endocrinologists. The patient-related barriers to the insulin initiation: hypoglycemia, personal failure, renal phobia, psychological and change in lifestyle, weight gain, cost, myths and misconceptions, and the burdensome regimes and insulin illiteracy. And the physician also has some barriers actually to initiate insulin. The compassion fatigue and the burdensome regimes and poor and inadequate communication, lack of time per patient, fear of doctor shopping, and adverse effects of the insulin therapy. So this slide shows the contributing factors to diabetic burden of India. The Indian reality is totally different, and the patient barrier, what we said, and the physician's barrier, what we said, and finally, the patient with a disability is the ultimate sufferer. And coming to third part, how to initiate insulin. And insulin conversation should be like this. A conversation about insulin initiation should be started shortly after the diagnosis. You just put a word about insulin. What happens in diabetes? See, the insulin levels, they go down, and on the other hand, you have insulin resistance. Whatsoever the insulin you have is not properly utilized by the liver, fat, and muscle. That is the reason you are not able to get back to normalcy. And the basic culprit in both, either the insulin resistance or insulinopenia, is the reduced levels of insulin. So tell the patient honestly that you don't have insulin, but to start with, I don't need to give you insulin at this particular point. So it can be managed with the other modalities. The only exception in the field of endocrinology is only the type 2 diabetes, wherein you have multiple modalities of the oral drugs or the injectable anti-hyperglycemic drugs, whereas the basic principle in endocrinology is so the replacement therapy. Suppose the LT4 is low in hypothyroidism, you just have to give LT4 only. Nothing works apart from LT4. Like growth hormone, okay, you have to give only growth hormone, but the only exception being the type 2 diabetes mellitus, where there are multiple modalities of actions, because I said the ominous octet postulated by Ralph Anthony DiFranco, that is the eight pathophysiological culprits which contribute to the hyperglycemia in different aspects and different parts. So the timely conversation provides an opportunity to set a positive context for insulin therapy. This helps to prevent a sense of guilt or personal failure regarding insulin initiation among patients with type 2 diabetes. Healthcare providers should focus on open-ended questions and identify the need of patient and address any concerns regarding the insulin therapy. And the sample conversation is given in between the patient and the doctor. Diabetes is a progressive disorder, and insulin is the only option that we may have to consider in the future. This should be conveyed very politely to the patient at the time of diagnosis or the second visit. When the body reaches an insulin deficient state, insulin has to be supplemented to ensure good long term glycemic control and to prevent the complications. And starting an insulin does not mean that you have not managed your sugar well, it is just the natural course of the disease. This is very important. And coming to the last part, the choice of insulin at initiation, the ground realities of the Indian the type 2 diabetes scenario. This is the survey called Impact Survey. The bar diagram clearly shows an insulin regime with best glycemic control and a simple insulin regime where you can see the respondents actually. The number is 10.3 in the first one and the respectively 7.1. And an insulin regime which can balance efficacy, safety, and convenience is 82.6%. Majority of the respondent, the healthcare professionals preferred an insulin regime that can offer efficacy, safety, and convenience at initiation and while continuing insulin therapy. And the need for a good postprandial control right from the start. That is, the left hand side you can see the cycle going on, that is called the glycemic triad, which is the fasting plasma glucose and the postprandial plasma glucose and the HbA1c. This triad is called the glycemic triad, and that results from a meta-analysis that increased postprandial glucose and fasting plasma glucose drive an increase in the A1C, and the postprandial glucose has a stronger correlation with HbA1c than the fasting, because most of the times we had gone through the slide showing that majority of the time the Indian patient is in the postprandial state rather than in the fasting state. So the shortcomings of basal insulin actually, these are the pitfalls if you use the basal insulin actually. So the on the left hand side you can see the basal insulins. So basal insulins actually they inhibit the hepatic glucose production at the level of liver, and they lower the fasting plasma glucose. And then what about postprandial plasma glucose? Basal insulin is good to start with along with the existing VADs. There are multiple rhythms, the algorithms to initiate insulin. So out of which the basic one is the basal insulin, or the second thing is the biphasic premixed insulin, or the next one is the basal bolus insulin regime, and finally the best out of the world is this co-formulation, the one and only the insulin aspart and insulin degludec. It's a combination of both. So basal only therapy is inadequate to address the challenges of Indian reality. 75% of the patients fail to achieve a target A1C at 1 year when initiated with only basal insulin. And these are the indices for holistic choice of insulin therapy. The holistic choice of insulin therapy in the center. The lower hypoglycemia, it should have the qualities like what I am going to mention. On the one hand, you should have a lower incidence of hypoglycemias and mealtime flexibility, and the regime must be very simple, and the convenience of the disease is very important, and better quality of life it should offer, and it should be cost effective, and it should be very efficacious. These are all the ideal the characteristics of an ideal insulin therapy. And with this, I've finished my talk. And thank you so much for patient listening. And any questions or queries, please type in the chat box so that we'll take up the Q&A session at the end after the second speaker finishes her talk. So I'll hand over the session to ma'am.